During the 1990s, the Robert Wood Johnson Foundation's groundbreaking support study examined how patients who are near the end of life are cared for in American hospitals today. In the second phase of the project, nurses were hired and specially trained in each of 5 research centers. Their goal was to improve patient care by facilitating communication between patients, families, and staff.
I think what support can tell us is how we can better care for the dying and focus our resources on things that will make a difference to them. And that may not necessarily be the technology, it may not necessarily be the number of ICU beds that we have available. For some it will. But it will help us to determine what is the experience of these people who are this sick and who are dying. And I don't think we know that, and I don't think we know how to deal with them in a way that's compassionate and in a way that's caring.
The cases you will see in this video were filmed during the final weeks of the support project. They are not meant to be representative either of the goals or of the conclusions of the study, but rather to illustrate some of the complex realities of end-of-life care and decision-making.
Coming into a hospital these days, not only are you sick and in need of care, but the pace of it, the technology, the number of people that are in and out of any person's room at any given time is so great that it's hard to keep a perspective on the person that's sick.
You know, like I said, there's like 20-some people involved in his case. You know, he's got kidney problems, he's diabetic, he's got heart and all this other stuff. And you never know who to talk to when you need to find an answer.
Yeah.
It just scared me because I didn't know what to do. And all these things go through your mind. Well, what if something happens? What do I do? What do I start with? I mean, I didn't even know who to talk to first or anything, you know.
It's been kind of confusing with this changing of services, and you felt like you needed more information. And so that's kind of why we gathered you together here, is to give you an opportunity to talk to the doctor and to find out some of the answers to your questions.
Right now, I don't think you're going to get much better in this, because it's becoming more of multi-medical problem. It's not only your heart.
A couple of times they had told us that if he would start filling up with fluid and that, to take him to emergency. Well, how do you know when it would be
too much or
or the right time?
His feet and legs always look swelled to us.
yeah, always.
I mean, they were extremely swollen recently, but how long do you wait until you think he's critical or something?
What we can do is, when we...
Mr. Riley came into the hospital for bowel surgery several months ago, but a heart failure and consequent need for open-heart surgery, a later episode of acute renal failure, and other complications postponed the operation.
He was so discouraged, and he said, you know, I just don't care anymore. I'd rather go home to die than I would to stay here and go through all these treatments. I don't want to go under one more thing. I've been here for months. I came here for a simple surgery. I want to go home.
You know, hospital stays kind of have a momentum. The longer you stay in, the weaker you are, the harder it is to care for yourself at home.
One of the things we most fear, for ourselves and our loved ones, is being trapped in the hospital, lonely, helpless, and in pain.
I mean, I had some mean surgery there, you know, and I don't know what happened or what the hell went anywhere. I'm telling you, I was begging for something. It hurt so bad. I'm begging them for any damn kind of morphine or...
They tried everything and nothing was helping. Then they ended up taking him down to anesthesiology, and they put a thing in his back where it would pump through like Novocaine constantly.
Nerve blocker
to help.
Or something. I forgot what they call that.
Yeah. So that did give him some relief.
Yeah.
Yeah.
What can you do? You can just beg. You need a quick fix then, or just let me go. One or the other.
To see somebody that you love and care about so much to be in that much pain, actually begging, you know, for you to do something to give him relief was really, you know, it's been real hard on all of us, you know.
If patients are living in pain or in the fear of pain, it can become the total focus of their hospital experience. They and their families cannot realistically evaluate their healthcare options.
I know you're receiving this medication. Do you think it's working?
It's working when I get enough. My problem is I don't always get enough, and it runs out. And I can't get any more until the time comes. And once it gets to hurting, he takes more pain medicine. I just can't get the right amount.
I was wondering how it is for you two also to see her hurting.
You just want to do something yourself, and what can you do?
She says she feels like she could go to sleep now, and this 50 mic load will help her get a little bit of rest too. It might not have been that she had an effective dose earlier. I'll reevaluate her tomorrow morning. If she does have pain, there's somebody here 24 hours a day who can respond to that. So make sure they know. We don't want her lying up here hurting and people not knowing that you can call somebody from PCA.
While we have made enormous advances in our ability to manage pain effectively, the application of these techniques is sometimes impeded by the traditions and culture of the hospital, and by the cultures of patients themselves.
It's remarkable to me how many people will say, I don't want to be any trouble to you, or and they're sick. They ought to be trouble, and or trouble's not the word that I want to use there, but that they have needs, and it's okay to have needs. And that's, I think, very consistent in some of the culture, too.
You know how to take those?
I already took the cap off.
Oh.
I did it for you.
We may sometimes imagine that there is a clear demarcation between living and what we speak of as the dying process. Yet many patients who have terminal illnesses nonetheless remain fully engaged in the needs and choices of their day-to-day lives.
He came into the hospital because he's had repeated troubles with shortness of breath. But I know that the medical team has been real frustrated because he'll come in for a few days, get stabilized, go home, be home for a few days, and come back to the hospital.
Have you talked to your daughter about how you're worried about being a burden?
We didn't go into a long discussion about it, but she know how I feel. Well, she said we can work around this, So you only have 2 rooms. We can work around it.
I think she's pretty fond of you.
It was her idea, all this,
Yeah. What are you expecting down the road for you?
I don't know. I didn't think I was going to be this sick this long.
We talk a lot about that just a few days left kind of decision making. But a lot of decision making that people do is the kind that Mr. Smith was doing today. Things that have a tremendous impact on their lives and how their existence is going to be, but don't necessarily deal with, am I going to be here tomorrow? But what house will I wake up in? And how will I eat? And what will I do during the day? And who will I see? And all those things.
If I was to say what would be your greatest hope right now, what would you tell me?
Get well.
I'm
really not able to do anything for myself. Somebody help you to the bathroom or help you down and up the steps. You say they don't mind it, but I mind it.
He's a person who was very clear that he did not want to complete a living will, and yet he has some strong feelings about his health care. He feels that the circumstances of life are too unpredictable to be able to say now what he will want at a later time.
Can you slow your breathing down some?
The one thing he's quite clear about is that he does not want to be resuscitated. He's tired of feeling so sick, but he feels it's important to keep going as long as he can, treat those things that he can, but then when it's time to go, just go.
Here, look at me a sec. Go.
Stanley, I know this is not easy. So if there's any way you can indicate what you need and I can help, I'd like to do that.
Mr. Lee is a relatively young patient with end-stage kidney disease. He has recently suffered brain damage because of lack of oxygen.
A 33-year-old with an anoxic brain injury, status post-VFib arrest on the 12th of December.
The medical team believes Stanley is in a coma and will not recover, and they are struggling with how aggressive to be in his care.
His primary surrogate is his father. He lives at home with his parents prior to having this event, and they've been very clear on what they want, and that is aggressive care. Their belief is that he never talked about any advance directives, never made any decisions prior to coming into the hospital regarding not wanting to be resuscitated or not wanting to be maintained on life support. And also they are strong Christians and feel that God should decide that they shouldn't make any medical decisions.
I think it's one of the more interesting dilemmas we face. I use the word dilemma not pejoratively, but it really stalls discussion about limits on care, because what do you say when they say it's God's decision? I never have any success in doing anything but working with families work through this, and usually the illness wins and not the clinicians. And
well, Stanley's father has decided to talk to Stanley about it, and that might seem silly to all of us because we don't really know what he can understand. I explained that to his father, but he does seem to nod yes or no to hurting and to some things. And I mean, what would be the ultimate best would be if Stanley could make his own decisions. Yes. And he's at a point where he can't, but maybe he can give his father some indications of what he wants.
what I wrote in my note yesterday is that we're going to walk a narrow line between fulfilling the family's wishes regarding aggressive care and not doing things that would be wasteful consumption of resources.
Also,
so
his
that means,
comfort with his bottom
that means
broken down.
Diagnostic tests should be limited. Lab tests should be limited to what we absolutely need. The therapy should be tailored to the problems and to comfort. And if he deteriorates, then difficult discussions will have to ensue, because it would be wrong to perform cardiopulmonary resuscitation on this gentleman with severe anoxic encephalopathy. He's never going to be able to make his own healthcare decisions, and as much as they'd like him to, that's not a medical reality. So we can do our part to keep his care good, solid, comfort-based care, in keeping with the family's wishes of being supportive, but we don't have to go hog wild here, so to speak.
As far as being the caregiver, being a nurse going into the room and having to, turn Stanley back and forth and see how his bottom is on fire. It's broken open, he grimaces, having to stick him for different IVs or different blood gases. Having to suction him is incredibly painful. He has spasms of coughing and he can't quite get up his secretions. And I sense from the healthcare team that they're really tired of having to put Stanley through all of this. They just, I mean, for what?
Mr. Lee is in a coma and cannot make decisions about his own care. Instead, his family and caregivers struggle to interpret what he would have wanted. Advance directives offer ways that we can make our own decisions in advance, before a time comes when we are unable to do so.
Well, a lot of times we use these family meetings as an opportunity to ask the patient questions so that they can express, and the physician's there to hear what is important to the patient for decision making, and kind of draw that out of the patient.
With one form of directive, called a living will, we can leave specific instructions about what kinds of care we do or do not want under specified circumstances. With a healthcare proxy or durable power of attorney, we can appoint a trusted person to make decisions for us if we are unable to do so ourselves.
I know one of the first times I met you, you felt it was really important to do an advance directive, and we worked together, and I explained to you how they can work for you. We did a durable power of attorney.
Yeah.
And I'm just wondering what your feelings are about that, if you still feel that's a real important document to you. Or,
Well, I think it is. Yeah, I guess so.
what were your reasons for wanting to do that?
Well, I don't want to be, you know, I mean, if someone haywire with me, I'd get a quick jump start on something. That's one thing, but to you know, plug in for some long-term crap, I don't want nothing like that. That's all. You know, basically.
So you're saying you'd be in favor of something that offered you benefit, but maybe not if it was just to prolong your dying process?
Okay. Yeah.
It's good for Dr. Arifai to know that, because he's going to be following you in the clinic, so it's important that you communicate.
It was important to him to set it down in writing and to put down that his wife would be a surrogate decision maker for him. He wanted the durable power of attorney for health care, and we did that. He was concerned about getting caught up in the system and having a lot of things done to him that he didn't participate in those decisions, and he wanted to make sure that that didn't happen. And I think he realizes after talking to him yesterday that his prognosis is poor and that his life expectancy isn't great, but the most important thing to him right now is to get home and to spend time with his family, and even if that means foregoing some of the more aggressive treatments to keep him in there a little longer, that's not how he wants to spend his time.
On 9C tomorrow? Okay. Yeah, okay. Nice to see you then. Bye.
Once controversial, today the idea of advance directives has moved into the mainstream. Physicians, lawyers, and a range of civic organizations offer advice on preparing living wills and healthcare proxies. Hospitals are required to ask patients if they have prepared directives and to offer them assistance in doing so. Yet it's often difficult to interpret exactly what these documents mean.
The problems we have with advance directives, or I have as a physician, is that often they're fairly vague, and the specific situations they give occur so infrequently as that they're not as helpful. The documents aren't as helpful as they could be.
It's frightening to see the assumptions that suddenly, with this piece of paper with very few specific words, you suddenly have a grasp of what this patient wants that may be very erroneous.
Or that it doesn't change, that this isn't a process that you need to evaluate and address on a regular basis as more information becomes available. That's not a static thing. It changes and should. What really bothers me is that it's become a task. I see on care plans, check the box. Do they have an advance directive, yes or no?
We've had the example of where a house officer's told that someone has a living will, and they go, okay, and they go and write a DNR order on the chart. And you have to go, well, wait a minute, they do want to be resuscitated. But people have, I think it's just the natural human tendency to want things to be black and white.
Yes, right.
You know,
Put it in the box. And
okay,
done.
are we going to do everything or aren't we? Let me know so I can get on with my work, and you can check the box and move on. The way they are helpful is that just the act of thinking about this and filling one out forces the patient and the family to think about this and talk about it among themselves, so that often they've had a chance to think about and deal with the issues, so that when problems come up, it's not hitting them for the first time, and they really have some sense of how to deal with it. And if the patient is too sick to participate in decision making, the family member is a little more confident that they do know how the patient feels.
Mm-hmm.
It's been a marked improvement.
Hi. How are you feeling?
Fine. My speech is coming back. I can use my hand now.
Well, let's see. Hold it on.
Mrs. Adkins has congestive heart failure and recently experienced a stroke. Her condition could deteriorate rapidly at any time, and the staff feels she needs to make some decisions about her care.
She's 39. She's long history of hypertension. She's had an MI in '92, and she just suffered a CVA this week. And so her, her overall prognosis is not great at this point. And I went in and talked with her the other day, and we started to talk about what might be important to her.
When people come and talk to you about it, it doesn't necessarily mean that something's wrong.
Right.
But the hope is to get people to talk about these things when they're okay, when they're feeling all right, and they're able to talk about them so that decisions aren't made later when the patient can't participate in them. Have you ever thought about any of those?
Yeah, I've thought about quite a few of them.
Like what?
Well, I don't think I would want to put a life support system if I had to be.
What do you mean when you say that?
I think I would be better off if they would just let me go, so let me, keep hanging on.
And are you talking to me about a breathing machine? Is that what you're talking about?
Yeah.
Are you saying that you would never want to be put on a breathing machine?
If it would help, I would be.
Okay.
But if it wouldn't, I don't think I would want to be put on one.
And I think that's a very important distinction, because a lot of times people get scared and they say, oh, I would never want that. I never want to be on life support of any kind. But what you're saying to me, again, is that
if it helped, I would want it.
You would
but if it didn't help, I can't see no sense in it.
So if it offers you benefit and they feel that they can use it to help you overcome, say, a respiratory illness or something, until you're able to breathe on your own, then you're willing to do that. Have you ever thought about, in terms of your heart, if you were ever so sick that your heart were to stop, how would you feel about, would you want somebody to try to restart it?
Yeah, I would want them to try to restart it.
All right.
But I want them to keep doing it,
Okay.
You can only do so much.
Right, okay. Have you ever told your husband?
Yeah, I've told him how I felt.
Yeah.
Because, well, I have little children. You'll have to think of them, too.
Yeah, this is hard. How long have you been?
About 7 years now.
It's pretty scary, huh? Yeah, this is a hard time.
We sat down, talked to him, explained to him, how bad it is, but they help a lot.
Do they?
The thing she was the most afraid of was to leave her daughters without a mother, and could really, I think that would be the thing I would be most afraid of. You try to stand back, and I wouldn't say keep a distance, because I don't think we can do our job well if we put too much distance, but you try to maybe do some sort of protective shielding, but we build strong relationships with these people, and they become our friends, and we become their friends.
It's hard talking to patients about these issues. It gets easier as you do it, and part of the reason it gets easier is when you do it, you realize, yeah, that was a very difficult topic. Yes, that was an emotionally charged, but when you walk out of the room, you feel like you've done something good.
What I've done is to write in on the Living Will.
In addition to helping patients think through and clarify their wishes about end-of-life care, staff may have an equally crucial role in interpreting those decisions to the rest of the healthcare team.
Hi, Mr. Eplin, how you doing?
Okay, how are you?
All right. It's good to see you, but I'm sorry you're back in.
Mr. Epland is 46 years old. He's in the hospital for at least the second time with angina pains, and also has been diagnosed with heart failure. There is a possibility that he could be helped by a heart transplant.
He is a potential heart transplant candidate, as best I know. But in this case, we have to be careful with the living will. We don't want that to be interpreted by the nurses and the doctors as his not wanting everything done.
Exactly.
He definitely, from what you're saying, wants things done. He just doesn't want to end up a vegetable, if you will, indefinitely on a ventilator in a nursing home.
Right.
That's a lot different from not wanting anything done.
Exactly.
So we have to get clear what his
Exactly
what he means, and if he wants us to put limits on what we do, because wanting a heart transplant is a 110% go situation. If the heart transplant people know that he's kind of like, if they think he's like, well, I sort of want therapy, I sort of don't want therapy, then he's not a heart transplant candidate. Those people need to sort of say, take my body, do whatever you want, as long as I get better, I'm happy.
Yeah.
And they do, actually, they do very well with heart
Mhm.
transplant,
Yeah.
so it might be a very nice therapy for them.
Yeah, okay. Well, what kind of, I'll sound it out a little bit, and I'll talk with you before I put anything in the chart.
Okay.
If you think that might
Yeah.
have an impact.
All right, great.
Before, when you were in the hospital, you felt real strongly that you wanted to do everything you could to get better, but that if things didn't go well, that you didn't want to be kept going on machinery and that kind of stuff.
Right.
And you had done a living will. If you're going to be a transplant candidate, be evaluated for a heart transplant, there's some question about putting a document like that in your chart because they need to know that you want to work hard to get better. It may be good for you right now to make sure that your doctors understand how you feel about that, but maybe not put the document in the chart so it wouldn't be misinterpreted. How do you feel about that? Is that all right with you?
Yeah.
Okay, all right. But, and if I remember right, your wife is pretty clear on how you feel too.
Yeah.
Yeah, all right. I know that this has got to be hard with both of you having been sick. You know, and when we spoke before, you would want to be one another's spokesperson. Have you any other people that you feel know you well enough that if one of you was in the hospital and unable to speak for the other person, that you would want to make medical decisions for you if you needed that?
I don't know.
Yeah. It may be something you haven't thought much about.
I think my wife knows me better than anybody.
Yeah. Really. In some ways, maybe we fool ourselves that we have more control over our leaving than we do, or more control over our health than we do. There are no guarantees. We can't promise people and stand behind our promise that once we know what you want, we absolutely guarantee you this is what's going to happen. That's hard to live with. That's real hard to live with.
The medical team caring for Mr. Lee feel that he will not recover from his coma and that the family should begin thinking about discontinuing mechanical life supports. An intern on the team has arranged to meet with Stanley's father.
And you know that, I mean, you admitted the fact that you don't think he'll leave the hospital alive. I just want you to be aware of what might happen and what you'll have to see and what you'll have to go through as he survives mechanistically with mechanical things and electric shock things to get his heart going and things that I don't necessarily believe he would approve of at that point. And when it comes to that time, you know, you say now that you're able to communicate with him and get the message of fight from him, it may come to a point that you won't know what he's saying because he won't be there any longer. It'll just be a body supported by machines. Mm-hmm. And he may not have any way to tell you that he doesn't want to go on.
What I feel in this matter is, you're saying we're gonna work, you're gonna go, we're gonna do what we have to do with fluids and whatever medication and support him until he got to that point. If he get to the point where he's comatose or completely unresponsive, then that's when I will make that decision.
Okay.
We realize that where he stands now, he could fall either way. He could go either way. The family is well aware of this. But my concern as father is give him every chance and every opportunity that we can for him to survive.
Did you discuss resuscitation, though, continuing on as we are? But if his
Well, see,
heart
resuscitation
were to stop,
I think would it would be left into the hands of the doctor at that particular point. Can you determine? Can medical technology determine if he got to the point where he needed resuscitation? that it wouldn't be worthwhile. Can you say that?
Well, I mean, I can't. There's no way to say 100% on anything. But I can say with 98% certainty right now,
yeah.
I don't expect Stanley to recover.
Yeah.
I don't expect Stanley that even if he was to survive, that he would ever become conscious, able to speak. I think that he'll remain in a hospital until he dies. And my greatest fear of all of this is that something may be done that's too late to turn around unless we make a decision now and look at things at how...
The staff are concerned that it may be much harder to discontinue life-sustaining treatments once they have been started than not to initiate them in the first place. They are urging Mr. Lee to make a decision based upon what Stanley would have wanted if he were able to decide for himself. But the two men have different perspectives on this, and for Mr. Lee, there are other principles at stake, including the needs of the family.
For you, you know, if he got to the point where he didn't even recognize us, you know, it wouldn't be the same to you as it would to me. Because even though he doesn't recognize me, he's there. I can put hands on, I can see him. And when I make a decision, knowing that my decision is saying I won't be able to put hands on prematurely, that's where I would feel like it's prematurely. It would affect me for a long, long, long time. And all of the other times that he's had these attacks, whatever it was, he kept fighting to live. See, this is Stanley that I know. And this is the Stanley that I know. And I want him to have every
You have the
opportunity.
history of Stanley that we don't have. Do you need to get back and check
Yeah, I
on
need
him?
to run back in there and make sure everything's
Okay,
okay.
okay.
I think you ought to talk it over with the family.
I have, and then we'll talk it over some more. I'll talk to him.
When the intern was speaking to Mr. Lee, he almost had tears in his eyes at one point. I rarely have seen family conferences where the medical doctors have presented their side so strongly to not continue on aggressively. In a way, we'd like to take the decision away from his father, make the decision ourselves.
I don't know what degree they feel, you know, the team, how much effort they want to put into this because of the deterioration of his whole body, because of all the other illnesses. But all I would want is to at least initiate it. And if there's no response, then there's no response.
And your sense is still that he's not saying, I'm ready to die.
Try. And when the supreme power, when God says, that's enough, it'll be enough, irrespective of what we do anyway. Might not do any good, but at least try. That's what I'm saying. That's all I'm saying.
I know.
If he's there, you can at least see him. But death is final.
The clarity which advance directives seem to offer can be an illusion. Each patient is unique, and the reality of each case can change from minute to minute. The same technology which under one set of circumstances can trap us into a long, drawn-out, and undignified death, under other circumstances may offer us meaningful extra time with our loved ones.
I think one of the things that often surprises people is that that there's medical uncertainty exists. I think that people often view their experience in the hospital as though the physician is going to be able to tell them when they walk in the door what's going to happen to them. And not only sort of specifically about what's going to happen with their health care, what time frame that's going to occur in. I think also that people oftentimes think that there is one clear alternative that's always the best thing, and that's not always the case either.
I have to go back to that case that I had with the family member. This patient had a surgery, and as the result of the surgery got a pneumothorax, not as a result of the surgery, but a common complication, they were putting in a defibrillator, and she got a pneumo. And the husband wanted nothing done because she needed to be put on a ventilator until she recovered, and have some chest tubes put in until she could recover from this pneumo, which was very treatable. But he came running in with his advanced directives, and he said, "You're not touching," you know. And really, I mean, in his heart, thought he was doing what was best for his wife, because he knew she did not want to be trapped on a ventilator. And they really talked to him at length about how this was a very treatable situation, and they felt they could have her off in a few days. But he heard one thing. He heard a young resident say, when the husband asked, how long would she be on the ventilator, he says, "I don't know, 2 days, 2 years, I don't know." And he heard 2 years, and he heard nothing else after 2 years. That was it.
So what happened?
Miraculously, she sat up in bed, and the doctor said, "You know, all I need to do is put in a chest tube and put you on a vent, and if it doesn't work in 2 days, we'll talk about it, and I'll take it off." And she goes, "Go for it." And she's home, and she's doing well, and she recovered. And
Well, the problem here is that people are put in situations where they have to make decisions about things that they know so little about.
Yes.
And this guy is trying to do what he thinks is best for his
That's
wife.
right.
He's trying to
Yeah.
protect his wife from, you know, the technology and all this stuff.
Absolutely, yeah.
And
I think it speaks to how hard all this is. I mean,
Yeah.
just to the fact that even though you think you're being very clear, or you try to use the best possible guidelines to make a decision, you know, when somebody's lying there dying.
it's very hard when you see something you can do not to step in and do it, you know. When people end up in untenable situations on ventilators in nursing homes, it doesn't usually happen all at once, you know. It's a lot of little things. It's some doctor saying, you know, if I just put this tube in, I can save your mother's life. And he goes, well, you know, I want to save my mother's life, put the tube in. And then they come back and they say, you know, we're going to need another tube. We're going to have to put that tube in. We better put him on the ventilator, but it'll just be for a short while. And before you know it, you end up in, yeah, it's, but it's real hard not to do it. And that's, you know, that's the problem.
I'm sorry. It must be so frustrating to try to say something and I can't. Did you have a question about the trach? Let me talk, and if I start talking about what you want to ask me, then start nodding your head.
It's the next day. Despite the predictions of the medical team, Stanley, the young patient with anoxic brain injury, has revived from his coma, and although with considerable difficulty, he is able to communicate.
I'm very proud of you. You've done great.
Well, I think, you know, with anoxic encephalopathy, I guess the teaching is what you get early on is what you wind up with. But he, in the 4 days I've been taking care of him, has made a very significant cognitive improvement. As Renee said, he fully interacts, he understands, he remembers nothing of being on a ventilator. When I asked him today about would he want to go back on a ventilator, just because I didn't believe Renee when she told me, I'll be very honest. I thought that she was just being her usual hopeful, optimistic self. And when I talked to him, it was clear he did not remember being on a ventilator, but when I explained to him what a ventilator was and why it might again become necessary, he understood and said he would go on it, although he paused and thought about it before he shook his head. So the communication isn't more than rudimentary, but it was very clear, A, he understands, B, he has a plan for his own care, and it makes it much easier for us to take care of him now. I feel much better about taking care of him now, regardless of the outcome. And I don't think he'll ever regain full function, but that is a prognostication that no one can make.
I thought if he could communicate to us in some way what he wanted, I thought he was going to indicate that he wanted to stop. But he said he wanted to continue. And with that information, I'm more comfortable with the plan of care.
I think that he's going to recover from his anoxic encephalopathy to the point where a warm and supportive family could take care of him at home.
He has come this far, one, because of excellent health care, but because of a family who refused to stop against suggestions
Yes.
by the healthcare team.
Very good point.
Medical opinion of the healthcare team.
Had I been his physician during the first 5 days of his illness when he arrested, I would have talked to them very strongly about limiting support. Absolutely, that's an excellent point, and it shows the fallibility of human judgment. Based on his early progress, it was completely appropriate, or lack of progress, to make him a no resuscitation, and may have been appropriate to discontinue support on him. And I don't know how many times we've done that where the patient, had we had an alternative universe to see what would have happened had we not done it, whether the patient would have survived to his level even now. So.
Hey, Gussie, there you go. Come up. Yeah, come on.
Gussie Hewitt is 90 years old and in the surgical intensive care unit. She was being weaned from the respirator following heart surgery, but now has become unresponsive. Her children and grandchildren have gathered at her bedside.
We need to be really tuned into what's important to people and how we as a healthcare system put in barriers rather than promoting a departure in which the healthcare team and family and everybody feel like not only has everything been done that it's possible to do, not just in the high-tech sense, but in the emotional sense and in the family sense and all those things, to try to make sure that the treatment that people receive is consistent with what's important to them and their family values.
There are times when the only end-of-life care that matters is the caring of friends and family, and the most important thing staff can do is to create moments when that can happen.
Yeah, and see, all your other brats are here. Look. Look, see? Hey, mama. Hey, baby.
Yeah, big mama, here we are.
Even though the situation may be tragic, you have the feeling that at least suffering has been relieved. You may not be able to change the ultimate outcome, but to help change the amount of suffering that it takes to get from here to there, that's a real wonderful thing. That's very rewarding.